All right, welcome back, everyone. Thank you for being so prompt to our afternoon panel with insurers. I want to thank representatives from Aetna, Anthem, and Cigna for being with us this afternoon. We thank you for your participation. This panel, so we're a little bit running early, so I think this panel will last a little bit over an hour, maybe 70 minutes or so. We have more panelists here and a little bit of extra time. Again, I'll ask the respondents to keep your answers to roughly 5 minutes or so to give everyone a chance to respond and about time for a variety of questions. I'm really thrilled to introduce the moderator for this panel, who is David Self. David is the first executive director of the Massachusetts Health Policy Commission, an organization that many of you are probably familiar with. They run and have for over a decade now the Massachusetts Cost Growth Benchmark Initiative, along with a lot of other really interesting health policy programs. Since their establishment in 2012, healthcare cost growth in Massachusetts has been below U.S. averages every year. So congratulations on that achievement. That has resulted in billions of dollars of savings for local businesses, families, and individuals. Prior to this role at the HPC, David was the special advisor on healthcare for Governor Deval Patrick and President Therese Murray. We are joined this afternoon for the panel by Dr. Rowland from Cigna, by Duncan Stewart from Aetna, and by Dr. Michael Jefferson from Anthem. So at this point, I will turn it over to you, David, to ask questions and introduce the panel. Thank you.
Great. Thank you, Dr. Gifford, and thank you to the panelists and to OHS for inviting me to participate in this really landmark day. Just to take a reflection that this is the first hearing to be held under this benchmark program in Connecticut, and the commitment of the stakeholders and legislators to be a part of today's hearing, I think is palpable. And the energy here and the discussion has been really, really thoughtful and in-depth so far. And I think we hope to continue that level of in-depth discussion this afternoon. We're going to be having a panel here with the health insurers, and then closing out the day with a roundtable discussion. I also just want to acknowledge and thank this invitation, because I've had the opportunity to come and testify here in this building and at the Capitol a few different times over the past 10 years, really sharing some of the experiences from Massachusetts that I think helped contribute to the governor's executive order, and then the legislature being able to take the bold action to establish a benchmark program in Connecticut. So it is a personal thrill for me to be back here today to see this truly a milestone in this effort. As has been said, Massachusetts, we were the first state in the country to establish this idea of a benchmark, this idea of an annual target for healthcare spending growth, and to really just, and again, to emphasize, to moderate the growth in healthcare spending in order to drive affordability for Massachusetts residents. I'm pleased to say that Massachusetts and Connecticut are not alone in this effort today. Today, there are now 8 states across the country that have benchmark programs, all with their own unique flavors and policies reflecting the unique markets. But across those 8 states, about 1 in 5 U.S. residents today now live in a state with a healthcare cost growth benchmark or target. So Connecticut, you are truly leading the way. You are part of a cohort of states, and I look really forward to continuing to learn from you and to learn from all of you here about how we can continue to evolve on these shared goals. As has been said, we have had 10 years of experience. We have 10 years of track record of looking at the data. In Massachusetts, our total healthcare spending growth has been below the U.S. average just about every year. Unfortunately, it is not every year. In the most recent year of data, 2020 to 2021, which is the data that we're reflecting here today, we were above the US average. And so we do see, similar to Connecticut, this acceleration of healthcare spending that has us concerned as well, and something we're going to dive in a little bit deeper here today in terms of this hearing. As part of our process, we also hold an annual hearing, very similar to this, where we're able to call different important stakeholders and leaders within our healthcare community to engage in this very thing, a data-driven dialogue about what is driving healthcare spending and how can we collectively work together. In Massachusetts, we call our hearing the Super Bowl of healthcare. Every year, I will leave it to you to decide what you want to call your hearing, but it is truly an event that really is trying to bring everyone to the table and to talk about solutions. And that's going to be a theme that I want to touch on in this panel today. We've heard a lot this morning already. We had a great testimony from a pharmacy manufacturer. We had a panel of some hospitals, and now we're going to be moving into this health insurance panel. And I'll start off the question with kind of a big general one, and if you have some opening remarks, you can feel free to kind of shoehorn those into those. But I do want to start with the statistics of, again, why are we here? And they've been said multiple times already today, but I do think they bear repeating. Nearly 50% of Connecticut residents report that they did not get the care that they needed or delayed care due to the cost of care. And 3 in 4 Connecticut residents are very concerned about being able to afford care in the future. We can have the best healthcare system, we can have the best health insurance plans, but if residents can't afford to even go to the doctor, go to the hospital, or choosing between splitting their prescription pills, as we heard about earlier, or putting food on the table, we have not succeeded in truly having a high-performing healthcare system that provides value to our residents. So I'm going to want to start there. We have this big challenge. We have these increasing trends, and we know that it's impacting affordability and accessibility. I'd love to hear from each of you. What role do you think the insurance companies or your insurance company has in helping moderate healthcare spending growth and drive affordability? And happy to kind of go down the row. Maybe I'll start with you, Dr. Jefferson.
Okay. What I would have to say first, just a little bit of myself. I'm in this position for 30 years, so I've seen where people end up when it isn't correct, not always the right, and also in EP quality and systems integration in DC. And so from those perspectives, I think that this stuff. And I could say half of my job now is cost of care. The other half is building relationships with those providers so that we can work together in bringing this cost down. So there's a component of care, but that last step these days is most of the value-based outcomes-based care. And that really does keep off. Start with that. Where are those outcomes? How do we reconstruct what is a volume-based system? And I would maybe bring one of my new colleagues.
You can phone a friend, that's fine.
It's most definitely director, provider, collaboration strategy.
Thank you. So paying differently for healthcare, shifting, as Dr. J said, shifting reimbursement from volume to value is an essential building block to improve the overall healthcare system and achieve full health. Insurers obviously play a critical role here. However, it will take all of us, the care providers, payers, and policymakers actively working together to create a stronger healthcare delivery system that addresses these trends. At Anthem, we do have a strategic approach that is deeply rooted in a provider-payer partnership framework that empowers care providers in Connecticut and across the country by A, contracting for value with reimbursement models designed to drive quality and cost outcomes through value-based incentives. Payment alone is not enough to achieve meaningful change in care delivery. which is why we're focused on collaborating for success and care transformation by supporting our provider partners with the data, customized support, and tools needed to manage population health.
Great, thank you so much. Certainly, health plans have a role in kind of the financial structures and the negotiations and the contracts that you put with together with, as you said, kind of collaborative relationships with providers. I do want to dive deeper into kind of the shift towards value-based care as part of the discussion today, so I'll come back to that. Duncan?
Sure, great. So I'm the president of the New England market. We're at most of the 6 New England states, both commercial and Medicare. I just want to start by saying thank you for, and I share the enthusiasm for having this conversation and starting to sort of more regularly engage with these conversations with all of the constituents. I think it's really important that that everyone involved across the system is involved in this type of dialogue, and hopefully we can really do this in the spirit of it takes all of us coming. Nothing good ever happens in healthcare without people coming together trying to figure out how to drive solutions together. I hope you'll take everything I say today in that spirit, in that vein, because you're not going to get a lot of finger pointing like it's the other person that's not productive. What we really need to do is collaborate and figure out the right solution here. So thank you for doing this. The other thing I'd say is obviously one of the areas that, as you noted, we're sort of outside of benchmark is really specific to the 2020 to 2021, specifically in the commercial market. And so I'll talk about that. But I think the thing that I know that at least from our perspective and comments I made today is that 95% of the residents in the commercial market in Connecticut who walk around with an ID card are actually self-insured. So this is where an employer pays us a fee to sort of administer a benefit plan that they select and define a network that they're really driving in collaboration with us. And I share that to say, I think conventional wisdom over many, many years, and I've certainly heard this here in other states, is that insurance companies don't care if the cost goes up, it's more revenue to them. That's not true in the commercial market where 95% of it is dollars that are coming straight out of the employer's bank account. So I can tell you with complete conviction that we stand with employers and we stand with the residents of the state of Connecticut in recognizing all of the points that you made to kick off are very, very real, and affordability is a genuine struggle for people. So we're very, very focused, and I would say to answer your question, employers have we have a critical role to play in terms of being at the table and one of the participants in driving affordability over time. You know, if you look at the things that tend to drive costs, you've got things like unit cost. That's a biggie for sure. And that's something that we have a good amount of influence over, as do a number of the other constituents that sort of testify on prior panel. You've got utilization, provider mix, and service mix, and there's probably a bunch of others, but high level, let's talk about them that way. Right, so utilization is where 2021 came off the rails. I think we all know for obvious reasons, you shut the world down for a portion of 2020. Utilization was going to go to downward pressure. In some places, double-digit downward pressure. And the following year, you know, due to exacerbation of chronic disease and so forth, or just delayed care for elective surgeries, all of a sudden that came roaring back. And I think your point is we're all sort of watching now and saying, is that a trend that continues, or are there other factors as you get beyond 2021 that we're starting to really drive that? So I'm sure we'll get into a little bit more detail on that. That's 21. Provider mix, obviously it's important. I would say that not unlike Massachusetts, Connecticut has quite a range in terms of lowest cost provider, highest cost provider. I'm not saying that to be critical of anyone, I'm just saying that's a reality. And so we have to think about sort of how do we drive more folks to more cost-effective settings that are high quality, and how do we do that? And we have a lot of ideas on that I'm happy to share. And then service mix obviously sort of impacts it the same way with the radical outpatient spike in behavioral health, that I think is a really good thing. We can continue to have behavioral health, right, and behavioral health and primary care, two areas that I'm sure my colleagues would agree with are critical at this point. And I won't belabor the point about value-based, it was very eloquently put, but that's one way that I think as we look forward to a significant amount of cost pressure that I'm sure my colleagues from the health systems talked about earlier. That we can start to sort of incorporate more of those types of things moving forward. Just to really finally sort of align incentives more meaningfully.
Great, thank you so much, and I appreciate your comments around a commitment to playing a role here and to being part of the solution. And collaborative spirit, I think, very much in line with the spirit of today's hearing. Dr. Rowland?
Thanks, Mr. Phillips. Good afternoon, and I'm Phil Rowland. I serve as the market medical executive for Cigna Healthcare in Connecticut. Dr. Gifford and Office of Health Strategy, we greatly appreciate being at the table for the cost growth benchmark as well as the quality council identifying quality benchmarks for our contracts and for providers in the state. I come to this position from a background in oncology practice and in the hospital and in medical group operations. It's given me a broad perspective of both the opportunities and the many challenges that we have in containing cost growth. I think to address your question at a high level, what can we do within our industry? I think first is working with our clients, the employers and the municipalities here in Connecticut, and the citizens we serve and our customers. First, working to maintain health and wellness. We spend so much of our time focused necessarily and importantly on chronic disease management, catastrophic illness. But I'm very much in line with Dr. Carter in the earlier session that noted we want fewer chronic disease patients in the hospital. And to do that, we really have to focus on wellness is cancer screening, moving the paradigm upstream to ultimately affect costs. Second, in doing that, I think we have to be major players in addressing social determinants of health. We know there are so many individuals in our community. We see when we meet with our various clients that 1 in 3 employees have one or more potential unmet social needs that inhibit their ability to live life at the fullest, to have full vitality. And I feel that we are well suited as an industry to serve an important role there. I agree with my colleagues in terms of behavioral health. Again, we see many individuals suffering from one or more behavioral health conditions. We know that worsens their overall vitality. We also know that increases the cost of care. So we have to address behavioral health. And then again, I'll echo the opportunities for value-based relationships, performing progression, maintaining those, developing and maintaining relationships with providers in the community with a combined focus on quality and controlling total medical costs. And I'm sure that is further into the context. Thank you.
Absolutely. Thank you so much. Thank all of you. And I do want to spend some time during our conversation today to dive into some of the specific cost drivers and the experience, not only in 2021, which I think obviously is important here today. It's the foundation for this hearing, but you all have a perspective of what's happening right now. And I think part of our goal with these conversations, what can we expect in the future? And so we'll definitely get to that. I think, you all mentioned at a very high level some of, well, first of all, I just want to say thank you for all 3 of you acknowledging and kind of committing to say that health insurance companies have a role here to play and do have a contribution to be made in terms of this collective effort. I think that's first a really important statement. And second, you all kind of broadly talked about some of the strategies you're pursuing to help guide that effort. I think big picture, taking kind of a global viewpoint though, like they're not really working. I mean, they're not really bending the cost curve. I think in a long-term trend here, we're seeing healthcare costs just continue to go up and more Connecticut residents really feeling like they can't afford care. So I do think we need to, this is a moment where we do need to double down. And so I'd love to hear from all of you, like, do you think you actually have the tools to help bend the cost curve? Do you need more? And what specifically are you most enthusiastic about kind of doubling down on as an effective strategy to help, kind of moderate the growth in healthcare costs, and happy to start with anyone.
Yeah, and say that, first, I hate to sacrifice the tools that we have now, and that's coming out regularly. Pre-authorization, utilization management, those I've always looked at essential, and yet I do believe we pay them almost as far as we can. Yet, they drive healthcare towards the other major tools which we are undertaking, of course. Now, that is care. Bundles and we've had call it one of the primary care components, which he's handled for the past 3 years with EPHC or again first medical care. But the bundle is for the special. And by creating fair, transparent bundling, they're based essentially they're the same for everyone. We can influence the marketplace. That is where economics are. And I really believe we can work collaboratively with our partners, specialists, and hospitals, and industry, with the right care at the right time. Without force, the people that make the decision best make them appropriate.
So I might just follow with each of you as we kind of go through this question. So just follow up. Can you just say a little bit more about the bundle program? What patient population, what markets are, is this commercial market? Is this Medicare Advantage? Where are you pursuing these strategies? And maybe give a little bit more about is it just hips and knees, or are there other types of clinical bundles of services you're working on?
Yes, broadly 13 different bundles,
Great.
not just MS, not just MSK, but GI, cardiac, and practically speaking, climate commercial. So it is different than Medicare Advantage, certainly Medicare states. Same principle. So aligning our incentives and aligning the quality of it providers. And most importantly, aligning with the patient's interests, which
And are you, what is the conversation with providers like when you're trying to introduce a different way of paying for, in this case, 13 different kind of sets of services? Are they receptive to, to entering into those types of contracts? What has been the uptake? And maybe, you don't have to name names, obviously, but in Connecticut in particular, do we see an uptake of providers willing to participate in these types of arrangements?
There was one of those providers sitting here not too long ago. They are receptive and they're eager for those kind of relationships. And they're just starting, of course.
So things, bundles, but we also have our enhanced personal health care program, which is more our PCP value-based program. So care providers that participate in EPHC are incentivized for delivering quality, efficient care by focusing on prevention and wellness, offering personalized plans and coordinating treatments across the spectrum of care. With EPHC, we have a fixed per member per month, a PMPM clinical coordination payment that compensates PCPs for important clinical interventions that occur outside of a face-to-face visit. These services include care planning, enhanced access, such as responding to emails or offering web-based visits, or following up with patients via phone or email to make sure that they fill new prescriptions. This type of proactive clinical coordination improves health and does reduce costs. We are seeing at Anthem meaningful progress when comparing critical health indicators among our commercial consumers and value-based arrangements to those who are not. Just some stats: 5.6% increase in breast cancer screening, 4% increase in HbA1c testing for diabetes, 2.9% increase in pediatric well-care visits aged 3 through 6, and a 5.6% increase in pediatric well-care visits 12 to 21.
That's great. I mean, certainly when you can change some of these financial arrangements and incentives can both, help moderate the growth in costs, but also improve quality and look at some quality finishes. I know that this is an area of interest for the office in terms of, how much money is actually in these types of arrangements, given, the large pool here. And I think as was mentioned earlier, from a provider standpoint, if, 10% of my revenue or 15% or 20% of my revenue is in kind of a value-based arrangement, whether bundle or through a primary care attribution model, a lot of my economic incentive is still on fee for service. And so it really requires kind of a change in the operating model on the provider side to not chase more services, but to keep people healthy, keep people well, and know that you're still going to be rewarded. So I think it'll be really important for the office to understand, what is the level of penetration for these value-based contracts? Are we getting to a point where we're actually changing the economic incentives kind of on a macro sense for the provider side? So I know that that's something that the office is going to be looking into, and certainly, if you're willing to share anything today about like a macro, how much are we talking about here? Like, those 13 bundles sound like a lot, but I can't imagine that that's more than, 5%, 10% of total healthcare spend. So, how we round things up and how we accelerate them, I think is going to be really important, but happy to hear any final comments on that.
So, in general, they're just starting. So, the Zinnias started several smaller. These will be rolled out from the state for January 1st.
Great, thank you. Duncan, what are some specific strategies that you've been pursuing that you're most energetic about in terms of having some results here?
Yeah, so I think if we're here to say something like this, I agree with you. This isn't moving far enough, fast enough. And I'm not saying that's anyone's fault. I'm just saying it's all of our fault. The issue you brought up in the beginning is still pretty real for individual residents in Connecticut, and we took a collective responsibility and we look there. That said, I can tell you, I was sitting at the Marriott in Hartford. I think it was just pre-COVID. Listening, it was the Moving to Value Alliance, like one of their meetings, and I forget who the presenter was, so apologies for not giving credit where credit is due, but they said that we were all talking about value-based contracts and what percentage of contracts are they, but that's not the same as the dollars that flow through. And they described it as, a big fat fee for service case with a thin layer of value-based costing. And I think it's fair to say that, that didn't really necessarily advance much through COVID, and for a lot of understandable reasons, I think, from all of our perspective. But I think as we sort of collectively get together and talk about some of the challenges that exist today, we perhaps need here a collective sense of responsibility that this needs to be driven forward. But also tell you that sort of value-based contracts are, if you've seen one, you've seen one. And when we first started talking about this years ago, it was sort of like, everyone running around planting flags, like how many of them do you have? That you sort of whoever said they had the most was actually the best. And it doesn't really play out that way when you look at sort of what's actually changed in terms of quality of care or outcomes. So there are good value-based contracts, and then there are ones that are just sort of like, you guys are just kind of self-reporting some things that like people just a different way to bucket what people just sort of simply view as revenue. I think we need to sort of more meaningfully get away from that. More progress is you're asking, I think, on the Medicare side, in terms of moving away from just sort of simply quality vectors, gaps in care closure into sort of action and cost. And getting to a point, you mentioned the prior auth debate. I would agree with you that needs to stay, but I would also, I think all of us have sort of grappled with how do we get better and more friendly and easier to deal with, as we're doing that. But I do think those things are continue to be useful tools. perhaps until you get people taking on full risk. Where, if you want to send people for MRIs who don't need them and you are paying for it, then I guess that's fine. But I think you start to see some of that utilization impacted if people really sort of more meaningfully drive down that road. I don't want to repeat comments that others have made. I would say one other thing that I would put out there that we're pretty passionate about is our ethical health product, which is a product that essentially sort of partners specifically with a handful of providers who have shown sort of high quality, more efficient, and driving high quality outcomes. And is really rooted in primary care, or as most of us here probably would like to get to advanced primary care. Sort of making sure that this is a pathway towards putting a team together that can sort of practice primary care medicine, including behavioral health, sort of across the spectrum for each one of their patients. So that's something that we're excited about, sort of some growing momentum. And I think that is a way, as I alluded to in my opening comments, to sort of impact provider mix. The one qualifier I would say with this though is that I feel like we have this tendency to sort of in healthcare, because it's just easier. The human brain finds it's easier, right? Mine does. It's either binary choice, right? It's yes or no. Should we do prior auth or shouldn't we? And the truth usually lies sort of somewhere in the middle. So I feel like we oftentimes don't have this sense of like, this provider should be in the network or this one should be out based on what their overall cost is. And some of us sort of really dive into the nerdy side of the data. You end up realizing that that's never sort of entirely true. And then you need to sort of really start to think through, where do you leverage each of the different providers and their strengths and the things that they're driving quality outcomes and so forth. So as much as we're excited about it, health, we're also excited about sort of how products like that continue to evolve in the marketplace and provide sort of more affordable options for residents of the city.
Thank you. And I, your comments about kind of not all, if you've seen one value-based contract, you've seen one, certainly resonates with me, and also, reflecting, especially in the commercial space, that those are still subject to market leverage and negotiation. And so if you're negotiating with a provider that is a must-have in your network, they may negotiate better terms on that value-based contract that would limit their losses or provide greater bonuses. So it doesn't mitigate some of the underlying market dynamics.
You mentioned sort of the go forward look. I would say if there's a beacon of hope here, it's that you're starting to sort of see some amount of a greater willingness, I would say, across the environment to sort of engage in broader discussions about that. The one thing I would say to qualify and speak there, and just candid honest here, is that there's a lot of pressure on costs. I'm sure it was addressed this morning. So the asks are getting larger, which is not good for affordability across the state. But since the asks are getting larger, I think there's a general understanding that, if you're going to start off asking for larger things, and wherever we end up settling, more of that's going to have to get packaged into sort of moving the needle in a meaningful way with value-based contracts, not just sort of this first rate, well, we've got some stuff going through it. It's essentially the revenue.
Yeah, I appreciate that. And I would just share, in Massachusetts, we have seen a plateauing of kind of the proportion of value-based contracts pre-pandemic, and that has kind of plateaued. So I do think it may be an opportunity for our states to think, to think together about how we can really accelerate this, because it really needs to get supercharged. I think that's going to live up to its promise. I do want to come back to the question about asks. But first, Dr. Rowland, just interested in any specific strategies that your organization is pursuing that you're enthusiastic about.
Thank you by asking for the curve. And I would agree with everyone here that we have to dig further, that we've got ways to go. I'd also like to acknowledge that I'm not sure where the real curve is. I don't want to use the COVID-19 pandemic as an excuse. We can't. I don't think we can overstate the pure disruption in healthcare in our society. And I think we're all needing to see where the steady state will be. But wherever that curve is, I am optimistic. Some things that I'm excited about, the fact when I meet with physician leaders around this, they embrace value-based care relationships. I believe confident that providers in our state They continue to be competitive, they want to do well, they want to be recognized for top quality care and high value care. And patients, our citizens, want to have high value care as well. And so along those lines, our approach includes a collaborative accountable care program. These are high-level value-based relationships with the largest provider groups throughout the state, focused on quality. Quality is a necessary entry using national benchmarks and total medical costs. So they're looking at total medical cost trend, the trend of that group compared to their comparable market. And as we've heard here as well, I think we do have positive results. We are bending the trend with these groups, and that includes lower hospital inpatient spend. We've been able to stabilize outpatient spend. One of the things we've seen in the driver in the post-pandemic is pent-up demand that I think is coming forward. We have in these groups improved cancer screening, well child visits, and primary care. And in fact, our primary care spending within these collaborative relationships is higher. We actually meet or exceed the 5% benchmark in primary care spending in those groups. But we do have to do the work. We have high penetrance in the state, but it's not high enough. We're actually bringing on another collaborative, actually July 1st this week. And so I'm very enthused about it. And then the second would be what I've talked about so far is really primary care focus, but we also have to include our specialists. And so we have Signacare designation for high performance specialty providers in primary care. It encompasses 21 specialties. The goal is to identify those individuals that practice the highest level based upon evidence-based medicine guidelines and in the top quartile or better in terms of total medical costs. And so we use that network to try to drive our employees, our customers, and the citizens of Connecticut again to the highest value care. And so I do believe we're bending the curve, but I would prefer that there's much work to do.
So let's talk about some of the underlying drivers of what we know is driving spending, and thanks to the great work of the office and the contractor, Mike Baylett, we actually have some data at hand. And if you weren't here at the beginning of the day, we had a great presentation. And some of the categories of service that have been identified as being, big contributors to spend were hospital outpatient, 30% growth in the commercial TME in 2021, hospital inpatient, 20% growth, and pharmacy. I have looked at enough data nationally to know that hospital and pharmacy are two big buckets that have been trending above benchmark for many years, not just in the 1 year that we're looking at, recognizing kind of the unique features of 2021 with the utilization rebound. So let's start with on the hospital side, hospital inpatient and outpatient. What are you seeing as the longer term driver of that? Is it that we're using a lot more hospital services? Is it the price of the hospital services? Is it more patients moving to the highest cost providers, kind of in that provider mix? Like, what of those different dynamics that we know can drive spending are you seeing as the major contributor over time in hospital spending?
I'd have to say yes. And practically speaking, many of those drivers, Dr. Carter cited very nicely by explaining people have been set up. And I said, there's also more places for them to go, excluding primary care physician. Yes, 90 more for them. Still not. That really, and to the governor's point, we need to not to double the expenditure, double the service. And even as far as primary care goes, I think it does have to be holistic wellness spectrum. It shouldn't just be primary care doctors or the other aspects that we like to see in primary care practice, that is nutrition. Not necessarily embedded behavioral health, but definitely coordination of care. I don't even think the statistics capture PAs. That first practitioners, but I think we're underrepresented what actually did happen. And in fact, we shouldn't over-represent those others. Another practitioner that I really believe is very essential in offices, navigator or health. They're the engagement specialists. Us guys, we're the medical specialists. We need to communicate to engage our patients, you know, in ways that they trust us. That's the foundation of our business. You say,
I want to return to primary care, but just to keep on the hospitals for just one moment. I mean, Duncan, you kind of raised it. The asks are coming in. You're at the contracting table, and obviously we're not going to expose any confidential or proprietary information here. But I have to imagine the pressure is on to increase unit price increases, and the providers may be providing a whole list of different reasons to justify that, whether that's labor costs, inflation, increased acuity of care. But nonetheless, these price increases are going to be baked in forever. I mean, they always create a new floor. What are you seeing in terms of the pressure from providers on health plans to say you need to pay us more money, regardless of the benchmark and affordability and all this other stuff?
Sure. So, I try not to see it because I don't take Jim's call. No, I do that. Look, the reality is, I think you hit on a lot of the points there. We're hearing obviously inflation, staffing shortages, the cost of traveling nurses, and that one seems very, it's astonishing how much some of the systems have been paying. You start to do the math, it's there are situations right here in Connecticut where during roughly the time period we're talking about, 21, 22 in particular, there are somebody in an operating room, the hospital's spending more on the nurses than they are for the surgeon. If you multiply it out annually. So I think that one's real. I mean, candidly, they're all to a certain degree real, right? But we have to balance this with the needs of employers who, the self-insured employers, they're all dealing with the same issue. They have staffing shortages, wage pressure, inflation. So this isn't something that's necessarily unique to healthcare. So yeah, the asks are outsized. I would say it's a range. It is not unusual for a year in Connecticut to get asks that are low into double digits right now. That's obviously in terms of everything you picked up with from a cost perspective. So those are proving to be somewhat challenging conversations. Some of the value-based conversation gets sort of reintroduced to that. But that is definitely, I would say part of the reason that we sort of lean toward do you do like some sort of a value-based thing is it doesn't reset the baseline. It's exactly the same. Yeah. And I think there's even an acknowledgement from, and I would say this is across the spectrum from smaller health systems up through including very large health systems that we oftentimes sort of work in these sort of, for lack of a better, like 3-year increments. Yeah. Like let's do a contract that's going to last a period of time because they're all offset and they all only have so many resources to work on the state and so forth. But we've had plenty of situations where that conversation becomes too difficult and it's sort of like, none of us actually know what inflation is going to look like a year from now. Right? We're all worried about it. But we don't know. And so do we sort of shorten the duration and say, we've got to live with something for now. We're not going to lock into that for multiple years because employers cannot.
Yeah, I think that it's really well said. And my concern with some of these very real pressures. Some of them are temporary. Even with the temporary nursing and staffing, we're seeing that nationwide, some of those costs start to go down. But when contracts with 10 double-digit price increases are agreed upon, that's a new baseline forever in the future that Connecticut residents will be paying for. And if I know these are the asks of double digits and not necessarily what is being agreed to, but there's no way Connecticut's going to meet the benchmark in future years if that's anywhere close to the reality. So, and this is maybe a question for all of you. Are you talking about the benchmark? The fact that Connecticut has a state law that says we're all trying to work together to kind of moderate this growth. Is that something that is even being discussed?
It is, yeah. I haven't had the benefit of this right in front of me, but it's a little first, and then more, 100%. It sounds like we're pretty unified on that. But, yeah, we 100%, we are talking about it. I would say that there are a range of responses in those conversations. And there's a decent number of I guess, conversations where the other side of the table is sort of like, there's no way that can be that, not in today's environment, like that's gonna be changed. And so, I will tell you, for everyone that does say that, there are others who understand and we're coming in under leading that. So it's to a certain degree, I guess you could kind of write it off as that it is a negotiation tactic, but I sort of feel like that there's the blessing and curse. We think we've seen this in Massachusetts to a certain degree as well, right? There's a blessing and curse of having a benchmark. But as soon as you put the benchmark out there, pretty much every health system is like, that's my minimum. Like I'm getting at least that from you. Whereas we're sort of like, we've got to manage to the thing and also we're trying to sort of level things out a little bit so that the range disparity isn't this right in a particular state, right? So that becomes difficult to do, but I would tell you I'd still rather we did it because the pros versus the cons, it's particularly in an era like this, I think we wildly problematic if we didn't have something in the benchmark that is revealing the conversation. So I'll let you guys seem very eager, so.
I'll put a yes in. He's certainly not wrong, but what I might add is use your metaphor, the Super Bowl of health. And having been on both sides of those days, most of the time, on the hospital side, the other side, it is like a football game. And you are, doing your best for that player. And there's a wrong motion in the vacuum, but the reality is it's just a play. And so these complex negotiations are not 100 parts, they're 1,000 parts. And each time it's not like you're, and I've heard people say that it's being held over the table's head all the time. It's not like that at all. It's a little scrimmage right there. And that little scrimmage goes here, then it goes back here, and it goes here. And so it's much more complicated. That said, that is for every leader. Thank goodness he did with that aspiration goal. And we can use that as our goal. I'm saying, but practically, no.
Yeah, I think saying, goal line is important. I also think it's injecting into these conversations an element of public good, of saying, let's keep an eye on the people who are actually paying the cost of our healthcare system and keep their interests in mind at the table as well. Dr. Rowland, I do want to talk about prescription drugs next, but Dr. Rowland, if you wanted to add anything left.
Thank you. I'll just add in the conversation. I'm not too far removed from the bedside, and I can certainly acknowledge the challenges that our hospital colleagues have. Number one, the disease burden we see in the inpatient unit sounds incredible. And it's usually not just one condition, it's often multiple coexistent conditions. And then often a component of behavioral health. And so acknowledging the extreme complexity there. And also the staffing piece that is very difficult. And I would agree that we are very mindful of the benchmark moving forward. As medical director, I'm not involved directly in negotiation, but certainly in the room. And I think it's a positive aspect for us that we establish that benchmark, that sets some expectations for the future. Therefore, we have to continue to work with our constituents toward a zero and ultimately a negative trend. Ultimately, try to meet that.
That's great, thank you. I want to shift gears to the other driver that was identified, which is prescription drugs. And we heard earlier today from one manufacturer who testified that while their list price is going up, they are also increasing their rebates at a commensurate rate, such that the net price of that particular drug is not actually going up at all in terms of what the health plans pay. Is that your experience, not with this drug, but across the pharmaceutical sector, that whatever list price increases that they're giving you an equal and commensurate rebate such that pharmacy spend is flat for your organizations? Like, I'm trying to reconcile. We know pharmacy spending is going up, so help me understand that. Is it utilization? Is it not?
I guess nobody's quite as eager as I I can't claim that I pulled data in that way to look at this specifically, but I guess I'd answer that. I doubt it. It might have been true with a specific, I wasn't here this morning, but so, I mean, that could well be true, but I don't think that that's likely true across the entire system. So I would say that that is my strong hunch.
I will acknowledge, I'm not able really to speak from the perspective of the prior presentation.
Yeah.
I would say though that in meeting with the businesses and municipalities on a weekly basis, pharmacy spend and specialty drug spend is the single greatest challenge that we have in terms of managing costs and affordability for our citizens. And so our focus there really is wherever possible, not to interrupt the physician-patient relationship, but to find the drug at the lowest cost where possible, see if there's an opportunity to change side of care to the lower side. I call it the lower side of care. That's really been a focus from my perspective and how we grapple with pharmacy.
So, I'm sorry, if I could just add, I think as we talk about all of this, I think it's important to also talk about and acknowledge, the good work that the legislature and the governor's office have done on even this past session. But that at the same time, there were things that were passed that are probably going to increase costs, specifically on pharmacy. We passed the legislature passed a piece of legislation that said a single prior authorization has to be issued and only, you never go back for cancer, MS, and autoimmune. So, to the point about specialty drugs and the like, now I can't use the tool of the toolbox. So I think as you have this conversation about what you see, and I don't know how you measure it or how you add it into what OHS does, but I think you have to say, or there has to be some acknowledgement about what is being done on the other side of it that maybe has taking the tools out of the toolbox. And I think that particular piece of legislation that passed is going to be a fairly significant cost driver, because we're not going to be able to say to a member, we know you're on this MS drug, maybe you want to try something else, or we'll work with the physician because the statute says you can't. So I think, I do think we have to have that part as part of the conversation. I think it's very important.
Thank you. Some of you may not work here at the beginning of the day, but at the beginning of the day, we heard powerful testimony from a consumer who was facing very high out-of-pocket costs for a critical drug treatment. And, her copays and deductibles was based on the list price of the drug, and was very significant and caused an incredible burden and challenge to get that prescription filled. When we asked the pharmaceutical manufacturer, he said, well, I would love to give you, make sure that you had the rebate, but I send that to, and I'll use quote unquote his words, middlemen, and the insurance companies, they take that rebate. It's up to them why you don't get to share in that rebate at the pharmacy counter. And so I think I want to ask about that because it was directly, kind of directed towards this panel. But maybe just as a starting point, can you just please explain to me which pharmacy benefit manager do you work with, and what is their corporate connection to you?
This is the easy one. I'll take that. We work with CBS, who happens to be our parent company, so predictably, it's definitely CBS.
We work with Carolyn RX, which is a division of Anthem / Elevance.
And we work with Express Scripts, which is part of the Cigna group of the Cigna Healthcare.
So across the board, the PBM is a division of a larger parent corporation of which your health insurance companies operate. And I can imagine that may raise some concerns in terms of consolidation, lack of competition, but there may be some opportunities for alignment. What do you say to this question of why not just pass along these discounts at the pharmacy counter rather than having the co-insurance deductible deductible based on the list price?
Preface it by saying, my mom and dad are on that medication now for 2.5 months. And it is expensive. Yeah, they didn't. And I would say, yes, we work with a PBM, but differently because it is cost. I would say cost of care is very care. And all the rebates are piled into that cost for our there. It's very transparent. Well, then,
Yeah, and I'll say on the pharmacy, on the rebate, at the point of sale, that does make it difficult in the situation where it's the employer's money that's being used. It's not necessarily the person who is at the pharmacy counter. So they may pay a premium for that employee, but it's a share of the employee, the total care that is being paid. And so I think that has to be kind of part of the conversation, is that and we're transparent, we put it in our filings and where the rebate dollars go, but in the situation of a self-insured customer, which as you've already heard, and for Anthem, it's 70% of our business. It is the employer's money. And so that's a question. Does the rebate go back to the person who's at the pharmacy counter who may not have even contributed but a small percentage to their employee premiums?
Yeah, but certainly contributing to their health insurance. And in this particular case that we heard earlier, multiple thousands of dollars to fill a prescription, for meeting deductible. This is the average American has like $600 of savings. And so these are real affordability challenges at the pharmacy counter that lead to some pretty devastating decisions. And I just would love to hear more from the plans. How are you working with your employers to mitigate this? Because what ends up happening is that patients don't get the prescriptions filled, their treatments filled, and end up with much worse health conditions. And so interested in any more from the other plans, any innovation that you're doing on the point of sale and actually trying to get more affordability at the pharmacy counter.
Yeah, so I'll just later on to the previous answer. I wasn't here this morning, so I'm not sure all the specifics necessarily. And I'll just sort of talk broadly about some things that we're doing. One of the programs we make available to employers to ultimately extend directly to the members is a program that sort of looks at the coupons that are available from pharmacy manufacturers, and then sort of takes those and removes the cost sharing to the member. So the member ultimately doesn't, instead of having a cost share, they have no cost share to participate in this program, and it ultimately decreases their cost out of pocket, which is critically important, as but it also decreases the cost of revenue for them. So I think that's one example, I would say, of innovation we can bring in to customers so that they can ultimately sort of share in it with members with the needs.
Thank you. I guess we'll start by first off thanking the consumer for sharing a difficult and honest story. And I will be very transparent that I don't have an easy answer for that. It brings forth many of the complexities of the system. High cost drug, high deductible, needing to incur that expense at the very beginning of a planning year. I've learned from that I don't have a good answer yet. I would say the concept of sharing in that cost and the deductible. The goal is to engage the member in their care, and I do think there are cases that there will be benefits. I want to change this stuff because as an example, I'll say an individual needing a colonoscopy who has a certain pocket expense is going to work with their provider to see if that procedure occurs in a hospital-based environment or perhaps in an outpatient. Where's the lowest site high quality very different. But again, it was a very difficult situation. Thanks for bringing it forward. And I would say in terms of rebates, my understanding is that rebates are certainly a consideration in plan development that is unique with a given employer. And I'm not really able, from my perspective, to share the details.
Understood, and thank you for that. I mean, this is the nature of these conversations. These are really complex, and I want to create a space where we can acknowledge complexity but ultimately results in real life challenges for residents here. I might push back slightly on emerging evidence on high deductible health plans, which is finding that they lead to members deferring needed care. And ultimately ending up in an emergency department at higher rates. Those disproportionate rates of both deferring care and ending up in an emergency department are higher for people of color and for low-income individuals. So I do think we need to think about how far can we push deductibles, honestly, before we've again created another affordability challenge. I want to turn it over to Dr. Gifford to see if you wanted to chime in. I have a couple more topics, but I know I've been dominating the microphone.
Thank you. I do want to make a general observation, and then I'll turn it back to David. I've been doing this work for quite a long time. And one thing that I know for certain is that every party needs to be at the table to come up with solutions. I will say I'm a little bit struck by some of the comments that seem slightly removed from the accountability that your organizations have for helping us solve this problem. And I hope you take that in the spirit in which it is offered, which is as an invitation to join us in really serious work to address affordability. Not that you're not engaged in it, but I think we need to up our game to David's earlier point here in Connecticut. We've seen a lot of understandable and justified pointing to other parties, not just from you, but we've heard it from providers, we've heard it from drug manufacturers, we've heard it from PBMs. There's a lot of, well, if that party would only do this step, then we wouldn't have this problem. Ultimately, sometimes it comes back to well, if the patient would just take their medication, we'd all be in better shape. So I want to say that, we need you and your leadership here in Connecticut to join us in this journey. It's an open door at the Office of Health Strategy. I know the governor is very anxious to have you all engaged in real solutions and facing those tough conversations with employers and with the providers that you're negotiating with. So I really appreciate you being here. I think it's been, an instructive conversation, but it's saying to me that I think we are really just at the beginning of this journey collectively. We will be bringing you to the table for these conversations, and we really have an expectation of vigorous participation. And I know some of you have been participating in our cost growth benchmark steering committee. We're grateful for that. We're grateful for that input. But we really need action on the ground and look forward to working with you on that. Back to you.
I like your term phrase for fruitful or pursuit. And we are definitely willing to join you in those conversations. That's why we brought all our parties here, our government there, because we need the policy. And it and fee for service. And we need to in earnest.
Well, I mean, that sounds like a pretty good place maybe to end the conversation, but I'll ask one final question, which just builds off of what you said. What can policymakers do to help? What would you recommend in terms of thinking about the next session? What tools should the state of Connecticut be thinking about enhancing that can help accelerate this collective action? And maybe not repealing things that happened in the last session. I can see
That wasn't gonna be my
I'll start by saying just thank you for the openness, and I would say moving forward, just please consider all sides of an outcome, looking to affect the tools that we do. I assume with any decision you make, there's pros and cons, advantages and disadvantages. But please think about how we might use that tool in our toolbox in the future to help control costs and get toward the cost growth. Thank you and continue to support innovations that we want to bring forward. You know, I think the unique thing about this panel is that although we're here as colleagues, we are competitors. And we do compete in this space to provide the lowest cost, the best value for the citizens of the state. And so allowing us some latitude for innovation, I think, in competition is something.
Lowest price.
So I'll just throw a little off the beaten path here. I just encourage to continue to stay with, you know, the approach that you're taking. But let's also sort of dig deeper into, you know, as we look to spend more on primary care, how are we holding every constituent? Put ourselves accountable to the offset, right? That can just be an increased spend. It needs to be coming out of somewhere else. And you know, the more that all of us can kind of commit to value-based care and risk sort of creates opportunity to do that. The other thing that I would say is that it's, you know, I mentioned the movie The Value Alliance earlier. I think that one of the leaders over there has often talked about healthcare here in the state of Connecticut. It's the land of frozen molasses. So it's very slow moving. But you know, every freeze has a thaw, and it's summertime here in Connecticut, and you know, things are really picking up, I think, in interesting ways, and maybe in part of the beneficial, right? But we are seeing a lot of new entrants to the market. This is with no sort of suggestion that that's necessarily bad. You've got organizations like Privileges, all of these entities that are coming in and sort of changing the dynamic of healthcare in Connecticut. So the thing I would say is that old saying about, you know, it's hard to put the toothpaste back in the tube once you squeeze it out. I think this isn't unique to Connecticut, as you know. There's been a lot of occasions over the decades in healthcare where it was like, oh, that's a lot of toothpaste on the counter. Don't know what we're going to do about that now. As the environment has started to sort of shift a whole lot more radically here in the state than it has previously, I think it would probably behoove all of us to sort of think about what does that mean to affordability and what does that mean to the quality of care and the access to care that various groups of people across the state have.
Thank you. Dr. Jefferson, I'll give you the last word. I don't know if you can beat the molasses metaphor and the toothpaste metaphor, but please try. Any final thoughts? I wanted to ask a little bit more about primary care, but, you know, feel free to go any direction you want to go.
Well, let me do the medical. The thing I always say about having these care is like, you get that general manager to do the work at their house. You can contract them a job price, and bring it to parts and material. Parts and material, well, see lots of work being really expensive assistant that they bring. Orders it can be practically speaking. What is the other? We don't help cares. The parts and material. And the difference now, hopefully, with two cases coming on. We will move towards what would be the job price with what is called disease. This disease wins the insurance. Health. Goal. Our great long.
Yeah, how do we shift to a health system? Well, thank you for the conversation today. It's been I could have probably done this for a couple more hours, but I think let's maybe end this panel there. Appreciated and just to say, please consider me a friendly neighbor to the north as you continue on this journey. Thank you, Dr. Goodrick.
Thank you, David. Before you step away, I want to just introduce two people who joined us. One of whom wants has some comments to offer. One is Ted Doolittle, who, as many of you know, is our health advocate here in the state from the Office of the Health Advocate. Ted has been an invaluable partner to us, the Office of Health Strategies, and found of creative ideas. We're very grateful for his partnership and glad that he could be here. Second is my colleague, Commissioner Andrea Barton Reeves from the Department of Social Services, who, as you know, oversees the Husky program here in Connecticut, and the commissioner has asked to say a couple of words.
Thank you. I will not be questioning it. I wanted to thank you for your courage in coming here today and answering questions. And also in that statute that you referred to, 669, which I'm not sure is quite a public act, there is an opportunity to invite our insurers and our hospital partners to the table to really have really informed and candid dialogue about the cost of healthcare. So although I am, as Dr. Kidd said, responsible for the state's Medicaid program, we at DSS are not naive to the fact that healthcare costs, whether they're Medicaid costs or outside of Medicaid, affect everyone in the state. So I'm sitting here today extending an invitation to you to be a part of that dialogue in a more open and expansive way so that we can all work toward really containing healthcare costs in a way that allows you to provide the quality of care that I know that you're committed to, but also allows it to be accessible. So this morning I was just at a press conference for baby bonds. So Connecticut is the first state to launch that. But part of what pushes families into poverty is out of control healthcare costs. So what we would really like to do is to have more of a partnership to manage those costs. And so that I wanted to take this opportunity to extend a formal invitation to you to engage in those dialogues with you in the department. So thank you.
Thank you, Commissioner. So with that, I will thank our three guests from the insurance industry. It's been a fruitful conversation. I meant what I said about, continuing as the commissioner emphasized these conversations so that, going into next year's report and next year's session and next year's hearing, hopefully we will have made significant progress on some of the issues that were touched on today. So with that, I think we will take just a few minutes of a break before we go to our final roundtable on affordability with some provider groups. We'll give you a chance to switch positions and be back in about 10 minutes. Thank you very much.
That